Well, for me, it was not an option. The article describes that when my only child, my son, was very, very young, he developed sleep apnea. And during that progress, being orthodontist, that I have been already involved with treatment of temporomandibular joints and also seeing some adult patient for treating managing sleep apnea. I knew that this science exists out there. I didn't know that how it impacts the pediatric. So when this issue happened to my son, and I'm hearing the impact of the jaws and airway and everything and upper airway, how it impacts the issue and development of the pediatric sleep apnea. I just had to help him. I had to dive to this science of the orthodontics and combine it with this sleep medicine science and come up with the rescue option for my son. So the issue of the sleep apnea and obstructive sleep apnea is the multifactorial, and there are some neurological issues, and but at the same time muscular and neuromuscular issues. But the significant part of it comes from the obstruction of upper airway. There are some terminologies that is called craniofacial changes, but there is an anatomy that are more specific. And we introduced it in the chapter that was published in 2019, Metabolic Therapies in Orthopedics. And scientists and clinicians from universities, they came up and published this book, and John Hopkins University and introduced this anatomy and concept. Pharyngo-orofacial is a concept that is more specifically talks about part of the craniofacial, that is jaws, joints supporting the face of the patient and also supporting, more important, the nasopharyngeal area. So the focus of the treatment for us is how to manage the proper growth and development and stability physiologically, biologically, and structurally, this pharyngofacial anatomy. So, and the focus is that start as early as age 3, when the patient has the first full deciduous dentition, and the system is going to be progressive, the way that we can uh, what we call let this anatomy properly grow. Don't do any mechanics and technology that is going to be restrictive to growth of this component, and then watch it to grow, especially the lower jaw, because the lower jaw is the factor that can get is more susceptible to damages, especially the condyles get damaged and slow down the growth of the jaws. And then watch this through the what we call the natural growth of the pharyngofacial system up to early 20s, and then how we are going to maintain this system through the life. And now we are pushing it through over 100, that not only the system is going to be stable, but is going to be functional and creates a stable, what we call cytosomatic environment for the individual. Now, as a result of this, how we are going to impact the pharyngofacial system, and there are some mechanics and technologies that they can be restrictive. They're out there, and the what I'm saying, that restrictive, meaning that in this technology we need to push everything away from the base of the skull and grow the jaws and pharyngofacial system, meaning that nasopharyngeal should be expanded by letting the jaws grow forward, wider, vertically higher, and that creates what we call um, container that contains the tongue large enough, wide enough, tall enough that the tongue can fit in it out of the airway of the patient. And the goal is to start as early as possible. Now, age 1, 2, when they don't have teeth, it is too early. We can see them, but at the same time, we cannot, as orthodontists, we cannot do anything about it. So we need to refer them for probably ENT evaluation if they have adenoids and tonsils. But at the same time, the technology that we have developed is early screening, which we go then going to talk about it, how to determine the patient has this issue and uh, what we call uh, treatments we provide that is going to expand this system. The term Teledantix and Telegenetics that is going to come around, how did it, um, you know, came along and how it has been, what is the meaning of it? Orthodontics and Teledantix, orthodontics and orthogenetics, meaning ortho in Latin, Greek meaning, Greek language meaning straight, orthodontics, straight teeth, orthogenetic, straight jaws. And the science that very well developed by uh, orthodontics as what we call the first scientist and clinician, Dr. Edward Engel, create the proper foundation for this. What is the science of orthodontics? Straight teeth, make the teeth functional. From the beginning, he understood that expanded arches are so important. And of course, orthogenetic, if your patient has jaw discrepancies that need surgeries. The term telegenetic that has been now in 2019 published in the white paper by American Association of Orthodontists is another terminology that practically instead of a straight jaw, meaning that tele moving the jaws to distance in order to expand the jaws, not restrict the jaws forward and improve the sleep apnea. Actually, that publication and also publication by American Academy of Sleep Medicine the same year, uh, clinical treatment of sleep apnea by American Academy of Sleep Medicine. They describe this technology, Teledantix, as the most effective treatment for treatment of sleep apnea. Now, in the chapter that I mentioned to you, metabolic therapies in orthopedics, there is a chapter that discovered and what we call elaborated, and uh, validated this concept of part of the orthodontic science and technology that now it is emphasized on not bringing things back and restrict them, but expanding away. So what is the great terminology that we can use go with hand in hand with telegenetics, and that was the term Teledantix, moving the teeth, moving the jaws to distance so we can expand these nasopharyngeal, facial, and pharyngeal airway. So that's the term Teledantix, telegenetics, and all the instrumentation from the early treatment at age 3, 4 to 95, everything is toward expansion of the pharyngeal system that starts from the nares in front by description of American Association of the Orthodontists white paper, start from nares in front, back of the base of the skull in the back, and hyoid bone, done there. And as a result of this, the technology that is developed, it is capable to expand the nasal cavity, nasopharyngeal area, oral cavity, palate as early as 3, 4, and then continuously on patients that uh, they have grown, the maturity of the mid-palatal joint cannot let the jaws expand easily. How in adult patient effectively with minimally invasive procedure as little as putting 4 TADs, temporary anchoraging devices, into the roof of the mouth and expand the palate as late as 63-year-old in female patient. We have been successfully expanding the jaws, making the airway, and this is a non-invasive. But not every case it is going to be like that. There are some cases that they don't want even non-invasive procedure. They are very fine, correct my bite. So the causing factor for temporomandibular joint issues and pain, which is the instability of the bite, is going to be okay. I know that I have a sleep apnea. I don't want to wear the CPAP. So I'm going to wear oral appliance that is going to hold my jaw forward and support my airway instead of CPAP. Those are the appliances that we have developed. Is the FDA cleared appliance called ApnoDent. And the ApnoDent, it can, variety of it, which is called ApnoTX, can be used sitting over the Invisalign, aligners, braces, denture, and orthodontists comfortably correct the bite and then ask them to wear it lifetime to manage the sleep apnea. So that has been the focus. But some of the patients, they want a permanent treatment. They don't want to just, after every 4 or 5 years, spend another $4,000 or $5,000 to redo this appliance. Although the appliance is very, very effective for management of the temporomandibular joint problems, is the orthopedic appliance for the treatment of the TMJ issues, is the bruxing appliance, anti-bruxing for management of the snoring. By bringing the jaw forward is very, very effective on intercapsular problems of the temporomandibular joint issues, and also very, very effective oral appliance. And this is the advantage of the appliance, is that there are a lot of appliances out there. Practically, those are orthodontic appliances, but they have what we call orthopedic, what we call headgear effect, meaning that as a headgear, push the upper jaw back, and as at one point, they made the upper teeth and upper arch a little bit farther back and more restrictive. So this appliance, ApnoDent, has the technology that is called mechanosensory transducer, meaning that with small stimulation of lower teeth with part of the appliance, again, mechanosensory transducer, invites the jaw forward and does not grab the teeth and push them back or push them forward. So these are for management. How about patients that they don't want to go through this and they want to just permanent treatment? We have developed the what we call telegenetic surgeries, that minimally invasive procedure that in matter of record 17 minutes, we can expand the lower jaw of the patient at age 75. We need to be equipped with this. Orthodontist needs to be equipped with this. And all the science of Teledantix and Telegenetics is orthodontic-based science. It's just another technology, another philosophy of how we are approaching the treatment. So it means that if by any chance just putting 4 tabs on the roof of the mouth cannot expand the jaw, well, then we need to have a backup option, minimally invasive procedure, which look like SARP, but is more sophisticated than SARP, surgically assisted rapid palatal expansion, expand the palate. The mandible, if you expand the upper jaw non-invasively, then the lower jaw also needs to be expanded. We have developed very, very sophisticated case appliance, $100. Order it. The dentist can order it, orthodontist order it, sit it on the first bicuspid. Surgeon, matter of 17 minutes records, reach from the inside the lip and expand the jaw 10 millimeter wider in matter of 2 weeks. And then, of course, the backup option is going to be telegenetic surgery that originally has been aimed at bringing the jaws forward as a maxillomandibular advancement 10 millimeter in order to improve the airway. We leave those options at the end. So the only thing that we need to change the paradigm in this system, concept of the Teledantix, expand away from the base of the skull and everything going to be expanded forward, vertically, and transversely. And also telegenetic surgery is not just confined to maxillomandibular advancement. In this technology, Teledantix telegenetic protocol, we have these techniques that are minimally invasive, expansion of the mandible, expansion of the maxilla in 3-dimensional, transverse, vertical, AP. Those are also, if is surgery involved with it, we call it telegenetic. So that's a little bit of change of paradigm. I know that there is a resistance, maybe there is to it, but we are doing it. And if we can do it, I told you that in the temporary office, now we have moved to the permanent office, but when I was in the temporary office with tutor, uh, office, I was doing it. So any orthodontist should be able to this because it's part of the science of orthodontics. Actually, there are orthodontic functional appliances. For example, the appliance that is used for the concept of the for managing the sleep apnea has been appliances that they origin from orthodontic, like Herb's appliance. Bring the jaw of the patient forward, and that is going to maintain the over. There are over about 100 appliances that are out there, but again, they have this headgear effect, action reaction. Majority of them, by bringing the teeth back, upper teeth back, and kind of protrude the lower teeth, it can change the body of the patient. The same thing is for functional appliances. For growing patient, we need to use part of the functional appliances that they do not have what we call the headgear effect. So as a result of that, when we were working on development of this novel appliance, ApnoDent, we developed this technique that does not have this what we call restrictive system and headgear effect. Now, we talked about how this system developed in my office 20 years ago when I started this, and of course you are orthodontist and you're using these appliances. For 10 years or 15 years, it was a rocky road. It means that mistake after mistake, trial and error. You use this, send the patient, and then you do the sleep test that see that is still you're not getting anywhere. Starting 5-6 years ago, changed the paradigm and started looking at different, again, system, non-restrictive system that does not bring the jaw back and actually can expand and push the jaw forward. From 5-6 years ago, started having less discrepancies, more success stories, to the point that today, by using the appliances that is developed by ApnoMed, and I need to mention a disclaimer that I am one of the founders of the ApnoMed Inc. and company, that is young startup company, and right now is seeking funding so we can rapidly grow these systems that are going to be easily make orthodontists now champions of the treatment for sleep apnea and manage of the sleep apnea. Or that's the issue, because orthodontists, we are going to talk about it, they have the majority of knowledge. They're just the instrumentation is not there, and ApnoMed has been providing this technology. Go ahead. So every single patient, doesn't matter how old, and we see patient at age 3 or 4, and patient that are 95 years old. That's the range of patient that I have currently in my practice. Every child, every adult needs to be screened. And there are some existing screening, what we call questionnaires in the market for adults. For example, is Epworth sleepiness test, which is practically is going to evaluate for the how sleepy is patient during the day, a pediatric patient, young child, or adult patient. But that is the level of just sleepiness, and it can be multifactorial. A kid that doesn't sleep enough, or adult that doesn't sleep enough, can get sleepy, but they don't have obstructive sleep apnea or airway disorders. So American Dental Association recruited a task force, 11 of us. In that task force, we worked for 2 years and developed a questionnaire. The name of the task force is CAST, Children Airway Screening Task Force, and we developed the screening question that now passed the pilot study, is going through the clinical trial nationally, and then after that, that questionnaire is going to be available. Unfortunately, right now is time consuming, is not going to be available, but at the same time, I have developed similar questionnaire and screening. That mine is the one that we have developed is more focused on, yes, airway issues, upper airway issues, also TMJ issues, and stability of the pharyngoorofacial system. That is going to be published in the book that is going to be published by CRC Press. Hopefully is kind of delayed because of my office situation and flooding and everything else, but hopefully it's going to be published in 2022 and has very nice short 5 screening questions that is going to make the clinicians to easily screen every child and then run them through the system. And if they have signs and symptoms of TMJ issues or sleep related um, airway issues, then they can recognize them and send them for treatment or start treatment on them. In United States, based on this the current knowledge, they say that somewhere between 40 to 60% of the adult and children, they may suffer from upper airway disorders, not necessarily obstructive sleep apnea. So it means that this, and we know the literature shows that patients, like Harvard's study, it shows that on monkeys, it shows that, if we have the airway issues, crowding and malrelationship of the teeth comes with it. So significant of number of patients that as orthodontists we see in our offices, they suffer from some sort of airway issues, not necessarily sleep apnea, but even during the day, mouth breathing is upper airway disorder, mouth breathing instead of nasal breathing. My practice is different. Of course, you can, but average orthodontist probably about maybe even 50, 60% of patients of their, that they see them as a child or adult, they may have upper airway issues, not necessarily a sleep apnea. Of course, my practice is different because I'm known in my community that I treat a lot of patients with a sleep apnea. So mine is high, 70, 80%, but the screening is the one that is going to, some of them, they come from TMJ problem or just the bite problem. But when you screen them, probably I can say the number of the somewhere between 70 to 80% of my patients. Again, this is the clinic that is focused on these issues. That's the percent of patient that specifically I see in my office that they suffer from these issues. In the Teledantix Telegenetic protocol, and I need to mention that this is the protocol that is floating between the science in dental and medical. It means that I'm board certified in dental sleep medicine and orthodontics. So I developed this technology that is going to be acceptable in 2 different worlds that now converging and are overlapping. Medicine, science of sleep medicine, and also orthodontic. They are very, very powerful, each one of them, and they cannot survive with the other one. Orthodontists, at present science, they cannot diagnose sleep apnea, at least in majority of states. So for in science and technology or protocol of Teledantix, telegenetic, sleep doctor is the most important what we call individual to do the diagnosis. So as a result of that, whoever that is going to adopt this, and this needs to be what we call early, doesn't matter at what stage of practice, young practice or established practice, you need to have a support in your community. And one of the important supportive what we call entities in your community is going to be a sleep doctor that understand sleep apnea, pediatric sleep apnea, adult sleep apnea, what are the causing and multifactorial reason for it. Obstruction of the upper airway is one of the reasons. If the jaws are small, pharyngoorofacial small and constricted, then not only the adenotonsillectomy can take care of it, expansion of the jaw. So it was important. So establish the what we call relationship with a sleep doctor, educate them, and that takes time. Again, it was a rocky years of 10 to 15 years. Now, almost every sleep doctor understand the value of these things. They know how orthodontics and dentistry is important. If they don't understand it, you don't want to work with them. And thank God there are plenty of, you know, clinicians and entities and sleep centers that they are going to listen to you. But that the sleep doctor and the sleep center should be your biggest ally, and of course ENTs, that how they work with you. That's how I had to establish this in the Teledantic, Telegenetic protocol. But that's something that, you know, how I approach it and how every orthodontist can approach it. I started talking about the CAST airway and what we call Children Airway Screening Task Force. By the time that this task force succeeds and the screening, uh, what we call the protocol and the questionnaire is established, and based on the uh, adoption of the uh, adoption by ADA, they adopted the issue of the sleep apnea. It is a valid concept in dentistry. Dentists are supposed to screen it, and dentists are supposed to manage it. Unfortunately, we are going to run out of the time that this is going to stay optional. So it means that for a couple of years, this may linger around, that you have the option of the, you know, getting into the airway and screening. But at the same time, from financial purposes and from the stability of, you know, longevity of the office and how lucrative it's going to be, this is the new wave that is coming. There are parents that are going to check around that who is airway, and, you know, like us, focus on the airway of the patient besides teeth and besides the face. And this is going to be something that is coming soon. But one thing that I really, again, this rocky road that has been for the last 10, 15 years, 20 years, now we paved it to the point that from now on is going to be just a cruising. Put it on the cruise control and go, and systematically you're going to have this protocol that is going to help you, again, as early as age 3 to age 90, and go through this. One thing that I do not recommend is that do not shove it into your staff's throat. You need to have an alliance. You need to educate them, because you don't want to have a resistance from them, but you don't want to do it suddenly, cut it dry, and suddenly stop everything and just focus on airway. Because if you're not established and still your staff do not fully understand this, there are going to be a little bit of chaos. My recommendation is do a little bit at a time, start screening, recognize this patient that they suffer from them, start referring them, establish relationship with your local community sleep doctor, ENTs. And then when gradually you're comfortable using these appliances, technique, and as orthodontists, we have, you have, or orthodontists, they have 80% of the needed science for this, how to move the jaw, how to recognize the pharyngofacial discrepancies, jaws are small, narrow. But the 20%, last 20% is very, very critical if we pick the right appliance or wrong appliance. It means that the wrong appliance is like playing a game of basketball with rules and guidelines of the baseball. They don't work together and it's going to set back. So gradually get comfortable with it, especially young practices. And I'm telling you, there is very, very easy from now on that at the established offices, you know, they have been around for 20, 30 years, get on this wave and continue. It is, first of all, is for the longevity office, and from the financial part of view, now you're going to have the means that, for example, Apnoden is paid by medical, and TMJ and therapy is going to also bring some other revenue, and these are hand in hand. And when you go through this and dive through this science and read about it, and go on teledantix.com, read about it on ApnoMed, you get some knowledge about this, and you see that how easy is going to be scientifically based science be implemented to your office. And of course, if we anything that we can help you with the book that is going to be published or articles that are already out there. This is going to be a paved road ready to just cruise on it, on cruise control.